This is Dr. Lauren Haggerty, one of our first-year fellows. And as you can see, the title of her talk, she'll be talking about reproductive health and kidney disease. So thank you, Lauren, for kicking off our grand rounds in 2023.
All right, thanks, Sarah, and thank you everyone for joining me today. I'm very excited to talk about what to expect when your patient is expecting reproductive health and kidney disease, with a real focus on how we should be counseling our patients with kidney disease as they navigate planning for pregnancy and pregnancy itself. So I'm not doing the traditional Zoom polls. I'm going to try poll everywhere, if I can advance the slide. So I have a QR code here. I'd appreciate it if you all would take out your phones and scan this QR code for our first poll question. When you get to the website, it's going to ask you to write your name. You can just skip that step. All of our poll questions are fully anonymous. So we got to our first question here. If you missed the QR code, the website is at the top of the screen. But the question is, how comfortable are you managing CKD in pregnant patients? I'm already seeing some answers and responses. I hope you all can see it too. It's kind of a smattering. I'll give a couple more moments for people to answer. Okay, awesome. So I see some people feel really comfortable. Some people are in the middle, and quite a few people are on the red frowny face, which is certainly where I was before starting this presentation. And I certainly am nowhere near the green side yet, but I do feel much better counseling my patients after getting ready for this talk today. So this is just to share that, I don't think I'm alone in feeling uncomfortable with pregnancy, and I think a lot of us are also in that same boat. Okay, so we will start with a case, and this is actually a case from the VA. So there are, women who get care with us at the VA. This is a 40-year-old woman with a history of type 2 diabetes who presents for evaluation of nephrotic range proteinuria and preconception counseling. She had a miscarriage recently and spoke to her obstetrician, and this prompted an evaluation for infertility, and that included a measurement of proteinuria. She remembers that she was told she had proteinuria during a prior pregnancy. She feels totally well today, and you do a complete review of systems, which is notable only for peripheral neuropathy and foamy urine. In terms of her past medical history, she has type 2 diabetes, which was diagnosed in the early 2000s, and diabetic retinopathy. She also has hypertension. She's had 3 pregnancies before. Her first in 2016 ended in a spontaneous abortion. In 2019, she had a pregnancy that resulted in a healthy baby who was born at term, though that pregnancy was complicated by preeclampsia. And in 2021, she had another spontaneous abortion. She currently is using an IUD for contraception. She takes metformin, insulin, and labetalol. She lives with her husband and a healthy child. She doesn't use any tobacco products, alcohol, or drugs. On exam, her heart rate's 81 beats per minute. Her blood pressure is 151/84, and she is well appearing and euvolemic. Labs show her creatinine is 0.79, and that really has been her baseline for years. Her hemoglobin's 13. Her albumin is 3.4. Her A1C is 7.7. Urine microscopy shows no cells, casts, or crystals. Spot urine protein to creatinine ratio is 4 grams per gram, and a urine albumin to creatinine ratio is 3.6 grams per gram. You send off a serologic workup for other causes, various causes of nephrotic range proteinuria, and that's all normal. And the patient ultimately gets a kidney biopsy, which shows diabetic kidney disease. So at this point, I think a lot of us, when we see a patient with nephrotic range proteinuria, diabetic kidney disease, we'd really be reaching for ACEs, ARBs, and SGLT2 inhibitors. But our patient tells us that her goal is really to expand her family, and a pregnancy is very much desired. So, with that in mind, those medications are off the table. And our patient really asks us, what should I be considering as I am planning for pregnancy, and what should I expect from the healthcare system as I navigate my pregnancy? So that brings us to our educational objectives for today, with a focus on reproductive health and kidney disease. First, what happens? What physiologically happens with the kidney in pregnancy, and what happens in patients with chronic kidney disease, and how might that affect their risks during pregnancy? Secondly, we'll talk about some management basics. A lot of management is very much disease specific and related to immunosuppression and the underlying cause of someone's kidney disease. We don't have time to go into that today, so we'll talk really about how the patient should be expecting to interact with their healthcare system, and we'll also talk about an update in hypertension management in pregnancy. And finally, I'd like to talk about the Dobbs decision and how access to abortion care has changed over the last 6 months and how that affects our patients with kidney disease who may not wish to be pregnant. So our first objective, what happens? We'll talk about the physiological changes in pregnancy. And I found this excellent visual abstract from the KI Reports community. They have a whole series of visual abstracts on pregnancy and kidney disease. But we'll go through some of these changes together. So firstly, we do see increased blood volume in pregnant patients. We actually expect about a 2-fold increase in erythropoietin in patients who are pregnant. And that comes along with increased cardiac output as well. We see a fall in systemic blood pressure and decreased systemic vascular resistance, which is related to increased levels of nitric oxide and resistance to angiotensin II. In pregnancy, we see glomerular hyperfiltration, which results in a decreased serum creatinine. Average creatinine in someone who's pregnant is around 0.4 to 0.6. And subsequently with that, we do expect to see an increase in GFR by about 50%. Pregnant people have an increase in urine protein excretion, which is mostly TAM horsefall protein. So the upper limit of normal for proteinuria in pregnancy is 0.3 grams per gram. The kidneys actually get about 30% larger themselves during pregnancy as well, which is thought to be related to nephron hypertrophy. And we also see physiologic hydronephrosis because pregnant people are growing another human in that same space. And so the ovarian arteries will actually compress the ureters, and that is expected to resolve once the patient delivers. So what changes in kidney disease in terms of fertility and menstruation? I think it's worth reviewing some of the hormones involved in the hypothalamic pituitary ovarian axis and how that changes in kidney disease. So in kidney disease, we actually see a decrease in the pulsatility of gonadotrophic releasing hormone from the hypothalamus, which in turn leads to impaired or disrupted FSH, LH pulses from the pituitary. This leads in turn to low estradiol systemically, which inhibits ovulation. There are a lot of factors at play here, but one of the leading theories is that all of this is, or a lot of this is at least related to increased prolactin level in people with kidney disease. Prolactin is renally cleared and then causes, if there's a buildup of it, it causes negative feedback on this hypothalamic pituitary ovarian axis. So what do these hormonal changes mean for folks? A number of things. And one big thing is that people experience infertility and a shortened reproductive lifespan. The average reproductive lifespan of someone who can become pregnant is 37 years. And in people with CKD and people on dialysis, that lifespan's 5 years shorter at 32 years. People also experience abnormal uterine bleeding, which is really more than just a nuisance. I think it's worth pointing out that people with abnormal uterine bleeding often have anemia, which may require erythropoietin stimulating agents or a workup for iron deficiency and treatment with iron because of that anemia. And it takes a real toll too. Some of you might be familiar with the concept of period poverty. Period poverty is when someone doesn't have adequate access to menstrual education or resources. And this really creates a lot of social, political, and economic barriers for people who menstruate all over the world. And we already know that a lot of social determinants of health are deeply tied to CKD. So when we pair period poverty with chronic kidney disease, with a worsening or changes, unpredictable changes in menstruation, that causes real problems for folks. And then, of course, we also see premature menopause in people with kidney disease, which is associated with a number of comorbidities, including increased risk of cardiovascular disease and osteoporosis. So our patient asks us, what are the risks of pregnancy and chronic kidney disease? And in my mind, I really think about 3 different categories of risk. One is, what is the risk with kidney disease itself? Will a patient's kidney disease get worse during pregnancy? The second category is, what are the other risks to the pregnant parent? What other comorbidities might they experience? And then that third category to me is, what are the risks to the fetus or the infant? So looking just largely at this table, we see stage 1 CKD on the left, stage 4 to 5 on the right, and HD on the, or intensive hemodialysis on the right. And really just like looking globally at the numbers without looking at the categories, across the board, we see an increase of risk in all categories as kidney disease becomes more severe. So this first category, progression of kidney disease, again, we see a higher risk of kidney disease progressing when someone has more advanced kidney disease. I saw a few numbers of creatinine being thrown around, with 1.4 being kind of a cutoff people use in terms of saying if someone has a creatinine of 1.4 or more, they're at higher risk of progression of kidney disease. And if their creatinine is 2 or 2.5, it's an extremely high risk of progression of kidney disease. We also know that people with an eGFR less than 40% or more than 1 gram per gram of proteinuria are at high risk for progression as well. In terms of risk to the pregnant parent, we see an increase of new onset or worsening of their hypertension. We can see worsening proteinuria, preeclampsia, eclampsia, or HELP syndrome. And in terms of risk to the infant or fetus, we do see that in more advanced CKD, babies have a smaller gestational age or lower birth weight, and they're more likely to be born preterm. We also know that infants born to parents with advanced CKD have a very high risk of requiring NICU admission when they're born. In fact, babies who are born to parents with advanced CKD have a 70% risk of needing to go to the NICU. Patients should also be counseled that they may experience in a flare of the underlying disease that's causing their kidney problems to start with. For example, people may experience lupus flares or worsening of complement-mediated HUS. So with this in mind, we recommend that all patients with kidney disease who are interested in becoming pregnant meet with both their nephrologist and a high-risk obstetrician prior to conception for counseling. Okay, so we're now to our second poll question and our second objective, which is talking about management basics. So the QR code is up here again if you've lost the website. So go ahead and scan that and we'll get to our second question. This one's about blood pressure. And again, the website's at the top of the screen if you missed the code. But the question is about hypertension and pregnancy. So what is your blood pressure threshold for starting medication in someone who is pregnant with mild hypertension? Okay, I think we've reached a steady state in our answers here. So people are using kind of lower blood pressures. I see 130 over 80. I see some votes for 160 over 110, and then in the middle, 140 over 90. Okay, so this is why I'm glad I'm talking about this, because I think pregnancy and hypertension is a different beast than our regular, benign essential hypertension. So when I was in medical school, and I think, as recently as 2019, the American College of Obstetricians and Gynecologists have consistently had this practice guideline of a threshold of 160 over 110 in terms of starting medication. So this isn't a blood pressure goal. This is just at what point do we start medication for someone who's pregnant and has high blood pressure? So this blood pressure goal came from a couple of older studies, but it's weighing a couple of risks. It's weighing the risk of uncontrolled hypertension, preeclampsia, and eclampsia, with the idea that a relatively low blood pressure may lead to lower placental blood flow and subsequently complications for the fetus because they're not getting adequate blood flow. But actually this year, a study came out, or I guess not this year, last year, actually on my birthday in May 2022, a study came out in the New England Journal of Medicine. This is the CHAP study. And the goal of CHAP was to really identify what that threshold should be in terms of starting medication for chronic hypertension in pregnancy. This was an open label multi-center trial in the US. They enrolled 2,400 pregnant people who had singleton fetuses, mild chronic hypertension, and a gestational age of less than 23 weeks. They randomized participants to 2 different arms. The first is the control group, and this was really the standard of care, that we don't start medications in pregnancy unless their blood pressure is greater than 160 over 105. And then, kind of with sprint in mind and knowing that we're aiming for lower blood pressure goals in non-pregnant people, they created a threshold of 140/90, and at which point they started medication for hypertension, with labetalol or extended release nifedipine being the first line choices, although other medications such as hydralazine were allowed depending on the clinical situation. So what did they find? In terms of their primary outcome, they looked at a composite outcome of 4 different features, one being preeclampsia with severe features. As a reminder, severe features include poorly controlled hypertension with proteinuria after 20 weeks gestation. It also includes features that might be concerning for eclampsia or HELP, such as low platelets, changes in LFTs, and any sort of neurologic change. They also looked at rates of placental abruption, neonatal or fetal death, and medically indicated preterm birth before 35 weeks gestation. So what they found in the control arm, that higher blood pressure arm, is that these outcomes occurred in 37% of participants, whereas in the active treatment group, that only occurred in 30% of patients. To me, this is still a very, very high percentage of an adverse outcome in a pregnant patient, but at least there was some improvement. Okay, great. And then in terms of the primary safety outcomes, what they were looking at, what's the risk to the fetus? So there's this concern of low placental blood flow, and subsequently, will an infant be small for gestational age? So they looked at the rates at which an infant would be below their 10th percentile when born, and there was no statistical difference between the 2 groups. Secondary outcomes in the study included other complications to the pregnant parent, including death, and also complications to the infant, and there was no statistical difference between the 2 groups in the secondary outcomes. So what's the take-home point this year from this study? This was practice changing for ACOG. They actually, before the study was published, they wrote their own new practice advisory for blood pressure management in pregnancy, and they are now recommending 140/90 as the threshold for starting medication. Again, we don't know what the blood pressure goal is in pregnancy. We just have a better idea of when to start treatment. So coming back to our patient, she asks, what are some best practices and what should I expect from my healthcare providers once I do become pregnant? And really the take-home message is that our patients should expect an interdisciplinary approach. They should see their nephrologist regularly. I saw at least once per trimester, quoted to as often as every couple of weeks. So I think it really depends on the degree of a patient's kidney disease. And as nephrologists, we can help to manage hypertension, proteinuria, and anemia. As you remember, pregnant people have a 2-fold increase in erythropoietin, and our patients with chronic kidney disease may not be able to mount that response. So they may require erythropoietin stimulating agents. Iron deficiency anemia is also very common in pregnancy, so our patients may need iron supplementation. We should also consider low-dose aspirin and calcium for patients who are at high risk for preeclampsia. And we should talk about thromboprophylaxis in patients with nephrotic syndrome and low albumin because pregnancy is a prothrombotic state. Patients should see their obstetrician regularly, and they should expect to meet with a high-risk obstetrician as well. And they may expect other specialty involvement depending on their etiology of their underlying kidney disease, such as guidance from a rheumatologist. Okay, so we'll come to our last objective, really talking about abortion access and contraception in our post-Roe era. So QR code's up again. We'll go to our third and final question. So this question is, how often do you provide contraception or abortion counseling to your patients? I certainly personally fall in the less than once a month category, which on a personal level is sad for me because as a resident, talking about contraception was one of my favorite things to do in my primary care clinic. This is to say, we're not alone. We don't talk about contraception or abortion frequently with our patients. We are very good at counseling patients on adverse effects of medications. For example, if a patient is going to start cyclophosphamide, we do counsel them on fertility issues. We counsel patients on ACEs who are starting ACEs and ARBs about the potential teratogenicity of those medications. But in terms of actually talking about contraceptive options, we don't do that as frequently. One survey of Canadian and American nephrologists showed that 65% of those interviewed did not feel comfortable talking just about women's health issues in general, including contraception. And the respondents who did talk about contraception with their patients talked to about it monthly to less than once a month. It was a rare occurrence. So with that, let's talk about what we can do after the Dobbs decision in terms of protecting our patients and how the Dobbs decision does affect our patients. So as most of you are probably aware, back in June, the Supreme Court issued their ruling on Dobbs versus the Jackson Women's Health Organization. And this decision ultimately reversed Roe, saying that individuals do not have a constitutional right on a national level to make decisions about their pregnancy. And what this has turned into is that it is now a state-by-state basis where each state has the authority to regulate access to abortion. So now we have this confusing and ever-changing landscape. I think the landscape was confusing to start with because there were restrictions in many states, but here's where we are as of 12 p.m. yesterday. I took this from the New York Times. They updated their map at 12 p.m. and I'll get to why they updated it in a moment. But really what we see on the left-hand side is huge portions of the country where there is either a full ban or a strict ban on abortion, including our neighbors in Idaho, who don't have access to abortion within their state. On the right-hand side, we do see states where abortion is legal, or at least legal but limited, and that includes Washington State, where abortion is a legally protected entity. It can be done up to viability of the fetus, and there can be exceptions after viability. For example, if the pregnancy is a risk to a pregnant parent's life or to their health, then an exception can be made. The reason why this map was updated yesterday is actually South Carolina. Some of you may have heard that in South Carolina yesterday, their Supreme Court ruled that legislation around a ban on abortion after 6 weeks gestation was unconstitutional. Many of you have heard stories about people crossing state lines to get abortion care, and we've actually in Washington and Oregon seen a rise in abortion rates in our states in the last 6 months since the Dobbs decision came out. And these added barriers to abortion and family planning care really create an increased burden on historically marginalized and disadvantaged groups. So, what does that mean in kidney disease? On the day the Dobbs decision was released, ASN released their own statement on it, and their argument is as such. They say parental mortality rate is already much higher than it should be in America, and pregnant people with kidney diseases and their infants are more likely to experience severe health complications, like I just spent the last 15 minutes, 20 minutes talking about. And so these decisions around whether to continue with a pregnancy should really be made by the patient with guidance from their provider and their own unique characteristics, medical needs, and personal needs in mind. So ASN opposes any effort to interfere with the practice of medicine, undermine the integrity of the patient-physician relationship, or limit access to our healthcare system. This ties in with an ACOG practice guideline from back in 2019, where they argue that abortion can be medically necessary in some situations. And they specifically point out people with kidney disease as people who may medically need an abortion to protect their own lives because pregnancy may threaten their lives. So we have a situation where in Washington State, access to abortion is preserved, but that's not the case in many states, including Idaho. And so I do feel that it's our job as, nephrologists and our patients' physicians to educate our patients and help ensure access to abortion if it's within their wishes, and also, for their own safety and health. So what can nephrologists do? I was very happy to hear that Jason is publishing a series on reproductive health care in people with kidney disease. And this particular piece from November focuses on adolescent reproductive health care, but I think some features do apply to adults as well. So I took this call to action figure, a snippet from it, to highlight what we can do for our patients. One is we can consider providing short-term prescriptions for contraception, or at least ensure that our patients are connected with primary care providers or other people who may be able to provide regular contraception. As a reminder, levonorgestrel, or Plan B, is something that is safe in kidney disease and can be given up to 72 hours after unprotected intercourse if a pregnancy is not wanted. And I think a lot of us may defer contraception to a patient's primary care provider, but our very own Suzanne Watnick might disagree with you on that. She at least feels very strongly that we should be educated and be counseling our patients on contraception. And she wrote this really great article from several years back, but it is a comprehensive review of different forms of contraception and considerations in people with kidney disease. We can also help ensure our patients are educated about abortion and have access to abortion services. That includes reviewing state-specific laws on gestational age limits and medical exceptions, which I just went over. We can familiarize ourselves with providers and clinics that perform abortion services, and we can consider advocacy at the local, state, and national level. And as a reminder, abortions these days are largely medical, done with mifepristone and misoprostol, given at less than 10 weeks gestation. The data on these medications is limited in people with kidney disease, but it is felt to be safe in people with CKD. So thank you all for your time today. I think my time is up, but I had a really great time learning about pregnancy and kidney disease. And thank you to all the people who helped me put this presentation together.
Thank you so much, Dr. Haggerty. We have time for a couple of questions. I'll open it up to everyone. Feel free to use the chat or unmute yourselves, as long as you remember to re-mute yourselves after you're done talking.
I have a question, Lauren. That was wonderful. Thank you so much. I was wondering if there are data on, a lot of these women have underlying conditions like diabetes, lupus, like you mentioned, and the initial data that you presented about, preterm birth, et cetera, for patients with CKD. Do we know if that's much higher than women with advanced lupus or without CKD, or diabetes without CKD?
Laura, that's a really good question. I imagine someone's looked into that, but I do not know the answer.
There's an NIH study on lupus, and if you become pregnant with an active lupus flare, I mean, that's a disaster both for the patient and the baby. So they generally want your lupus to be under control, especially if there's a major organ involvement. And then lupus nephritis to be quiescent for at least 6 to 12 months before you even attempt pregnancy.
Thanks, Abal.
All right. Any other questions? If not, excellent job, Lauren. Learned a lot, especially considering that I don't see these patients very often.